All right. Today, I'm speaking with Jason Abaluck, who's a professor of economics at Yale University. And I'm speaking with Jason about one of the most influential studies on public health behavior during the COVID-19 pandemic, the large-scale randomized trial on community masking in rural Bangladesh. We'll discuss what motivated this very ambitious project, the main findings, and also the strong reactions that the paper generated, both enthusiastic and critical. That's what I guess makes it even more interesting as a topic of discussion, both within the scientific community and the general public, and what lessons it offers for future public health efforts. This conversation is being recorded for the main purpose of hosting Jason's this interview in Eco, an Italian economics monthly magazine. And it's very timely because countries, including Italy and the United States, which is where we are having this conversation, continue to reflect on, lessons learned from the COVID-19 pandemic and how to maybe craft future pandemic response policies. Jason, thank you for doing this. I have a set of questions. Let me start with the first one.
Yeah.
Can you walk us through the main idea behind your study? What motivated you and the research team to conduct this large-scale randomized trial on mask promotion in Bangladesh?
Yeah. So thank you. First of all, it's a pleasure to talk with you about this. So I guess we should start maybe in March of 2020, when I first became interested in this topic, when basically I think COVID sort of penetrated the public awareness. And actually one of my colleagues came to me and was like, Jason, like, what do you think about the evidence on masking? Because it seems like most government health organizations are not recommending it, but doesn't this seem to be something that we should be considering? So I said, I don't know, let me look into it. So I started looking at some of the studies, and basically the existing studies were split into two groups. There were studies in hospitals, and some of them were comparing, for example, like surgical masks to cloth masks or things like that, or even higher quality masks like N95 masks. And what those studies seem to suggest is, yeah, when people wore better quality masks, this was prior to COVID, so these would be for flu pandemic or for just protection against the flu in hospitals, for example. And they would find, yeah, when you wore better quality masks, you were less likely to get the flu. So masking can, in principle, masks when worn can, in principle, be effective, excuse me, against respiratory diseases. So on the other hand, there were studies which you might call community studies. So community studies would be things like, oh, we went to a college campus, and during the flu season, we asked students in the treatment group, we had a control group and a treatment group, and in the treatment group, we said, please, wear a mask for a couple of weeks, and let's see if you're less likely to get the flu. And so they would say that to the people in the treatment group. Sometimes they would send them masks, and then they would test them, and typically they found that they were not less likely to get the flu. So my reaction to these studies is, I think, a reaction that would be shared, at least by many economists, which is, well, there's a critical thing that they didn't seem to be measuring, which is what economists would call the first stage, or compliance. How many people actually wore the mask, right? So on a college campus, if you say to people, hey, it's flu season, we want you to wear a mask for two months. Right? It seems like you might worry that, especially if you're the only one doing it, there wouldn't be a lot of compliance. And as we now know from COVID, even if you're not the only one doing it, compliance is a very difficult challenge. And now, to be clear, this is a very important thing. This is not saying that compliance is not relevant or anything like that. If what happens in practice is when you have a mask mandate, no one actually bothers to wear the mask, and therefore they're not effective, that is a very important thing to know. But the reason, when I looked at these previous studies, I was like, oh, it seems like they might be drawing the wrong conclusion in these community level studies, is because it seems like whether people will wear masks or not is very context dependent, right? So if you have a respiratory disease with a high enough mortality rate, and if the norm is that everyone should be doing this, it seems like something that you could get people to do. And if the idea is, no, it's something that most people aren't doing it, then it'll probably be hard to get people to do. So there's sort of this open question of in what context would people wear masks, but then a separate question of if they wear masks, will they be effective? So I spent a lot of time on that because that's an important thing that we're going to have to revisit later. It's a theme that we're going to return to again and again. So that's basically, Jason, yeah, go ahead.
Yeah, no, how did you address the first issue, the issue of compliance in your study?
So first in March 2020, I was like, well, look, we know that masks can be effective if worn from these hospital studies, but we really don't know how to get them to be worn. So the main motivation of our study was twofold. First, it was to say, can we come up with a suite of strategies that collectively will suffice to get people to wear masks, at least in the setting we were interested in? And second, if people do wear masks, are these effective at combating COVID? So a further important point to note that I've given sort of the thing that initially got me interested. At the time when we did this study, there was another major motivation, which is the alternative to masks was basically lockdowns and closures. And within the development economics community, the community of people who study, lower income countries, the idea was lockdowns generally don't seem feasible because there's a lot of people who are consuming hand to mouth. They earn money, then they use it to buy food. And if they're not earning money, they're not buying food. And this is not really an option. So the question was, are there other options that we can pursue, including masking? So my colleague Mushfiq Mubarak, who is one of the co-authors on the study, has done a lot of work in Bangladesh. So we explored a number of different settings. We settled on that as a promising setting. And basically, what we wanted to do with this experiment, so as I said, two goals. First, can we get people to wear masks? Second, is it effective? So I can talk a little bit about the different strategies we use to try to promote masking.
Yes, please. Yes. If you would do that, I just wanted to mention that this study was published in Science. I should have mentioned it in my introduction, but I just wanted to. Yes,
thank you. So, and again, let me talk a little bit about what was distinctive about this study. So it's a large randomized study. One thing that was distinctive about it is while the previous studies had randomized individuals, so they might say there was a study, the Danmarks study, that actually came out during COVID in Denmark, where they randomized some individuals to wear masks and not. And if you read the headlines about this study, the headlines were like, study finds that masking not effective in fighting COVID or something like that. If you look at the actual study, they had a treatment group where people were 18 percentage points less likely to get COVID than the control group. However, it wasn't statistically significantly different from zero. So what should we conclude from this? Well, like all the previous studies I mentioned, they didn't measure who actually wore masks. So one possibility from that study alone is they managed to get 18 percentage points more people to wear masks. Masking was 100% effective.
Extremely effective, but yeah.
Not effective. It wasn't a large enough study to find a statistically significant effect. Now, I'm not saying masking is 100% effective. We can basically rule that out from our study. I'm just saying that study certainly was not evidence to conclude that masking doesn't work because they didn't see how much masking increased. And the point estimate was actually a fairly large reduction. They just weren't powered to distinguish that large reduction from zero. Okay, anyway.
Because the key thing was they were not taking the compliance concern seriously, and they were they didn't have a way to look at that, what you call the first stage, like whether or not, the treatment group, those who were told wear a mask or encouraged to wear a mask, whether they actually, what proportion of them actually did wear one.
Absolutely. And just to underscore how serious a problem this is, there was one study done, I think concurrently with ours, I believe it was in Kenya, where they elicited both self-reported mask wearing behavior and observed mask wearing behavior. And I believe it was something like 80 to 90% of people self-reported wearing masks. And I think the actual percent who observed wearing masks in public areas was between 10 and 20%.
Wow. So classic social desirability bias. Are you wearing a mask? Sure, I'm wearing a mask.
Yeah. So you kind of need to observe people to see.
You need to observe people.
What we did in our study. So first of all, instead of just randomizing the individual level, we randomized at the village level. The idea there is this allows us to test not only are masks protective, but do masks do what's called source control. So if an infected person is wearing a mask, they might be less likely to infect others. So if you randomize at the village level, you can see is the whole village less likely to get COVID because of the combination of the protective role of masks, and the source control of masks. Another thing we do in the study is we observe. We had a bunch of people go around and count who's wearing masks in these public areas so we could see compliance.
So you placed your own research assistants or
exactly
in crowded areas.
Incognito, they're going around and they're counting who's wearing masks. Okay, and how many people are wearing masks. Now, before we actually did the full study, we did some pilots. Now, this study is kind of we wanted to run it quickly. Some studies like this, you do piloting for years and then you do the full study. We did, a couple of weeks of piloting. But in those couple of weeks of piloting, we learned some important things. So the first thing we tried was we said, we're going to have a person go from household to household and give you a mask and sort of explain to you why it might be important to wear a mask. We did that, and then we measured whether in the pilot villages where we did this versus other control villages, people were more likely to wear masks, and we found a pretty small effect. We found like a 9 percentage point increase, something like that. So essentially like 1 in 10 people were induced to wear masks as a result of our study, right, in the pilots. So then we're like, okay, can we, make this more robust? And the elements that we added to the main study were first the involvement of what we call sort of like role models. So like the imam in Bangladesh. So the imam would give a speech at the end of the services in the mosque, and they'd be like, hey, by the way, we're partnering with this program to help encourage people to wear masks. Here's why it's important. And then we also had people called mask promoters. So a mask promoter is someone who would, in the crowded public areas, especially the indoor ones, but also in Bangladesh, there's these markets, they're outdoor markets, but where people are literally like, less than a foot apart. They're packed together in these markets. And at the time we did the study, by the way, there wasn't very clear evidence on indoor versus outdoor transmission. I think later on, it became clear that a lot of transmission was indoor, although the markets are so crowded, it's not completely clear. But anyway, in these crowded public areas, what happened is you had a mask promoter who would basically look whether people were wearing masks. And if they weren't, they would go up to them and be like, oh, hey, by the way, here's a mask, please put this on. Now, of course, they're not doing physical violence. If someone's like, I don't think so, then they would go on to the next.
Leave them alone. Yeah.
Right. So it's basically like, look, encourage people to wear masks. And this helped a lot. So in the final study, we managed to increase mask wearing by about 30 percentage points.
So it went from the 10%, around 10% you had observed in your pilot to 40%?
Yes, exactly.
Almost.
And actually it is also true that in the control villages, about 1 in 10 people wore masks. In the treatment villages, it was about 40% on average.
Okay, now, so it's not like in the control villages, no one was wearing a mask. There was a baseline proportion of the population wearing a mask, and it was 1 in 10.
Exactly. And
how many villages were included?
So it was 600 villages in total. So 300 treatment, 300 control. We also had a bunch of sub-randomizations that we can talk about, surgical versus cloth, that we can get into.
It's a pretty remarkable effort. Anyone who has ever done any type of field studies, field experiments can appreciate how
there are hundreds of thousands of people. So even I had done some previous field experiments, but this is a different scale.
Super.
So the one other thing I was going to say is this 10 to 40%, of course, mass considerable heterogeneity. Like it's like some villages where nearly everyone ends up wearing the mask, and then some villages, even if they're a treatment village, where it just doesn't catch on. So the big question, it seems, is there a norm of mask wearing? If that's adopted, people wear masks, and if not, then they're more hesitant to wear.
So you mentioned you had several ways to encourage mask wearing among the treated populations. I imagine that because your main goal was to get people to wear a mask. So because your main objective was to measure the impact of wearing a mask on the likelihood of getting COVID. But can you are there any elements or indications from the study about the relative efficacy of the various approaches that you use to encourage people? Was there any specific method that worked better than others at encouraging people to wear masks?
Yeah, so it's a very good question. So let me talk about what we learned and didn't learn. So we had a bunch of cross randomizations, things like, what if we text people if they get a text reminder, are they more likely to wear masks? And we measured this using the color of the mask. So within villages, there'd be a household where we sent them a text reminder, we give them a red mask, and the non-text reminder, we gave them a blue mask. But then in another village, the colors would be reversed. So we're not just estimating the impact of the color, we're estimating the impact of the text messages. Basically, all these things like texting or changing the language or whatever, none of them seem to have had any impact. Okay, the one thing that does seem to have had an impact was the difference that I mentioned between the piloting and the full study when we actually introduced these mask promoters, the people who would go around and remind people to wear masks. We don't have randomized evidence of that. We just have the pilot, and then we did the full study. It was so effective, we decided to do it everywhere. But in the first pilot, we didn't do that. We had a much lower increase in mask wearing. The second pilot, we did do that. We got a much bigger increase in mask wearing. The full study, we did do that, and we got a much bigger increase.
Quick question, were the mask promoters members of the community? Did you
Yes.
recruit them from the community?
Yeah, so they're recruited from the community and they're participating in the study. So they're typically people who someone would know. A further point I should make here is just like, of course, it is true that this is context dependent. Like if you went into Alabama today and were like, no, first of all, I don't think would pass a cost benefit test anymore because COVID mortality has dropped so much. So I don't think we should be trying to encourage everyone to wear masks in Alabama. But if for whatever reason, there was some government program that was like, we're going to have mask promoters and we're going to distribute masks and we're going to inform them about, it's like, no one would wear masks because of course it's sort of, there's many, many political reasons why you would not expect that to happen. So
that would also be my prediction.
Exactly. So our point in this study is not we have figured out the secret sauce that will work in every setting. The point is, if you're in a setting where things are not too heavily politicized, where it's sort of like, we don't really know what the norm is, and there's a respiratory disease, and it seems like there's reasonably high morbidity and mortality, then this suite of factors can induce people to wear masks. And like, you could also have the opposite situation to the Alabama situation. If there were a new respiratory pandemic where instead of having a mortality rate of close to, let's say, 1%, which is what we saw in the initial most severe strains of unvaccinated COVID, imagine you had a respiratory pandemic with a 5 or 10% mortality rate, then you would see people routinely dropping dead all around you, and you'd be like, oh man, I better stay home. And if I have to go outside for any reason, I better put all kinds of things over my head to prevent myself from dying. So
of course, like you said, it's constant context dependent, but we did not have the evidence that you produced in that context, or perhaps in any context.
What I would say is before our study, we knew we had, I think, a couple lines of evidence before our study. There was the studies I talked about that were randomized studies in hospitals. There were also studies that just looked at, I wear a mask and I like cough into a petri dish. And you can tell like there's some conspiracy theories online that are like, COVID particles are too small for masks to be effective. And it's like, no, these laboratory studies show that if you wear a mask and cough into a petri dish,
they're pretty good.
They're pretty good at blocking those emissions. And then the third kind of study, which we can return to, are what economists call like observational or quasi-experimental studies, where basically you would compare places that had mask mandates and didn't. And these tended to show effectiveness, although we can return to, there's a number of important caveats for those. And one thing, so what does our study show or not? So first of all, I haven't
what did you find? Exactly. What did you find in the study?
So we talked about the first set of results on the increase in mask wearing. Then the second set of results was that we measured that people seemed to have less COVID in the treatment groups so they were about 10% less likely to be symptomatic seropositive from the 30 percentage point increase in mask wearing. Okay, so first, let's just put this magnitude in context, right? The first thing that's hard to do is like, how do we extrapolate this to other settings if instead of having a 30 percentage point increase in mask wearing, you could get everyone to wear masks? How big of a reduction would you expect? One thing you could do is just kind of like scale it linearly. You could say, it would be 10 over 3 times as effective or something. And then you'd be like, all right, you got maybe a 30% reduction in COVID. It's like, is that big or small? Well, at times when lots of people are dying of COVID, that would be a really big effect. But let me stress, there's a lot of uncertainty in how to scale that. Let me give a couple more caveats, actually. So one other caveat is, how are we measuring COVID? So we're measuring COVID by what we call symptomatic seropositivity. So first, does someone report any symptoms? If they report any symptoms, then we test their blood. to see if they actually have COVID. So in the study, we can also just look at symptoms, right? Do they seem to have symptoms that look like COVID? There, we're actually a lot more powered because people can have COVID-like symptoms. It's probably a combination of flu and COVID and other kinds of diseases or whatever. There we find a very strong evidence of a reduction in symptoms. For symptomatic seropositivity, part of the problem is many people won't consent to have their blood drawn. So the overall rate of symptomatic seropositivity ends up being substantially lower than the rate of just symptoms. We still find an effect, although it's like the confidence interval is pretty big on that. So it's like,
on the first part, it is intuitive because with a mask, you're not just blocking COVID, you're blocking the flu, you're blocking any other respiratory transmissible diseases. So that's
And now, but
remarkable.
Exactly. Now, one thing that we wanted to do, by the way, we actually tried to do a big follow-up study where, for a variety of reasons having to do with international transport of things, we couldn't get like approval to transport things. We went to a follow-up study during Omicron where we had to organize things very quickly because we didn't know the timing and we couldn't get the masks in time. But the difference in that follow-up study was going to be that we were going to blood test everyone, regardless of whether they had symptoms or not. And this would allow us to learn two things that we couldn't tell from the first study. So one concern with the first study is if, there's concerns about just like differential reporting of symptoms in the treatment and the control group. So it could be that, when we did this whole intervention where we encouraged people to wear masks, if people sort of psychologically felt like it was effective or whatever, and so they ignored their symptoms or were less likely to report the symptoms, that might show up as a reduction. Now, that bias could also go in the other direction. It could be that people were really attuned because we gave them these masks, we talked about COVID, so it could be we're understating or overstating. It's not totally clear, but it's definitely a concern. It would have been nice if we could blood test everyone. We wanted to do that in the follow-up study. We couldn't.
It didn't happen because of logistical, you couldn't make it up.
Exactly. The other big thing that we couldn't figure out in the first study is the impact of masking arising because it reduces transmission? Or is it arising, if you think it's a causal impact and not some misreporting thing, is it arising because of transmission, or is it arising because it makes a given infection less severe? So what could be going on is all the same people get infected with COVID, but there's a smaller viral load because the person coughs on them and they get fewer viral particles in their system, and so they're more likely to be asymptomatic or something like that. Now, that's still a benefit, potentially. It might be, you're getting fewer viral particles, and so you're less likely to die, something like that. But it could be that, and to be clear, we're not remotely powered for mortality in our studies, so we're powered for symptomatic seropositivity, so it could be that you're less likely to have a symptomatic infection, but or it could be that actually you're less likely to be infected to begin with. These would have quite different implications.
Yeah, I was going to ask you, what's the relevance of distinguishing between those two?
So a huge thing that we still don't know, even after our study and after all the other studies, is what is the long-term impact of masking? So there's a lot we could say about that. So it's a whole separate topic. So that we should definitely talk about. But when we think about the long-term impact, one thing that will be relevant, what we were just saying, is if we model the long-term dynamics of COVID, is this preventing a person who's infected from infecting other people, or are all the same people getting infected and they just have less severe infection? So if in a model, for example, where you think everyone is going to get infected and you don't worry about the timing, maybe actually just making the infections less severe is more beneficial, right? Or alternatively, in a model where you have a horse race between you're trying to prevent as many infections as you can, and once vaccines are available, infections become much less deadly, and over time, strains become less deadly. In a model like that, preventing infections early with masking, even if everyone ultimately gets infected, can reduce the total morbidity and mortality. So my bottom line is we can come back to this question of what was the long-term impact. This study is about a couple of months after you're, during and shortly after when you're wearing masks.
Do you have symptoms? Do you test positive? Those were the two outcomes.
Exactly. Symptomatics are positive.
Yeah, this is great. So let's get to the reactions. How was the study received? First of all, how was it received by the scientific community? And next, how was it received by the general public? I know you have a lot of interactions on X, formerly Twitter. What type of reactions did you get? Were there differences between reactions from the scientific community and reactions from just regular folks interacting with you online?
Okay, let me compare three groups, which are there are scientists who do this kind of clinical study. So I would say among that group, the reactions were like uniformly positive, and it was like, wow, it's amazing. You guys managed to do this enormous study so
Go
quickly.
science.
And it's like the study won a award, like got published in a top journal, and it won this award for one of the top 10 clinical research articles of the year.
Congratulations.
Right.
I didn't know that.
So,
Congratulations.
so that community, there was just basically unanimous enthusiasm.
Okay.
So then there was a community which are sort of like scientists who don't do clinical studies. Now there, I would say there's like, I still think there was general enthusiasm. Now, partly it's hard to say because it's like that community would generally be, now you enter the issue of like political bias where you have, so you have the first group is like the experts who are really qualified to evaluate this study. The second group are people with like some relevant expertise, but also the third group is no relevant expertise. There, it's just you have political polarization that informs everything. So what happened in the second group, I'd say there was general enthusiasm, but there were also critics. I think the critics, so let me talk about the kind of critiques that people made and how I would respond to them. So I think the most relevant scientific critique is in the study. So a thing that you often try to do in large-scale randomized studies is you want to do what are called balance tests. So you want to see, are the control and treatment villages identical at baseline on the things that you're trying to evaluate at end? And so the good news is for our study that we do see balance at baseline on all of our outcomes. So we see balance at baseline in terms of mask wearing, we see balance at baseline in terms of symptoms, in terms of symptomatic seropositivity. So the villages looked the same to begin with in terms of those outcomes, and then they look different at end. Now, the bad news is we do see some imbalances. Now, why do we see imbalances? Well, the main reason we see imbalances is that so the biggest imbalance we see is actually in the population size. So we saw that the treatment villages ended up being a little bit bigger than the control villages in terms of the total number of households. So this arose, my best guess, we still don't know for sure, but I think it had to do with the way that we actually, so the team that did the survey, so when we actually did the study, first the team surveyed all the different households to basically say, do a count of what's the village size, how many people are there in each village,
Okay.
and then they would go the next day and they would distribute mass. So because of our short time frame, we basically had the same team doing the survey and giving out the mass. So my guess as to what happened is that the team was like, well, if there's a household that's kind of on the border of the village, they weren't sure whether to incorporate it, and they were like, I'll incorporate it, and then we'll give them mass tomorrow. And they were a little bit more likely to incorporate it in the treatment.
So I don't want to get too technical, but so you did try to stratify on size.
So we did
but the implementation
stratification on population given the data we had, right? But then the actual counts of the number of households ended up being a little bit larger in the treatment village.
Understood.
So there's basically a bunch of ways you can try to adjust for this. One way, so as I said, they still looked similar at baseline in terms of symptoms and symptomatic seropositivity. You can also be like, does the size of the village, is it predictive of the fraction of households that were symptomatic and symptomatic seropositivity? And the answer is not really. Like it couldn't possibly, that imbalance wouldn't be predicted to account for our results. Now, of course, anytime you see an imbalance, you worry about other things that might be going on. And it's like when you do a study of this scale, it's not going to be perfect. So basically,
this was a technical objection that maybe, that caused some mild skepticism among some
this
types
I would say
of
is I'm giving this as an example of like a cogent objection, which is like, look, no study like this is going to be perfect. There is some merit to this. I don't think the right conclusion from this is like, oh, you should dismiss the results of the study. But the right conclusion is like, oh, okay, there was a small balance failure. We did the checks that suggest that it's probably not driving the results. That's it. Okay, so there was sort of that group, and I think so. There's then there's the third group of people who are just people who are political, and they're of course just going to be completely dismissive of anything that doesn't agree with their political judgment. There are some interesting individual cases we could talk about, like Jay Bhattacharya, the head of the NIH, and his response to this. I have a whole story I could tell. I don't know if we want to get into that or not, but
I mean, do you want to get into that?
I'm happy to tell the story. So basically, when we initially published the study, he wrote what I regarded as a pretty misleading tweet. So we didn't talk fully about like the different subgroups in the study. So I mentioned that we had surgical and cloth masks, and 2/3 of the treatment villages were surgical masks, 1/3 were cloth masks. So among the surgical villages, we found a statistically significant impact of masking on symptomatic seropositivity. They're symptomatic and then their blood is positive. Among the cloth masks, you saw a similar point estimate, but it wasn't statistically significant, and it was a tiny bit smaller. Okay. So Jay's tweet was like, oh, and I think he reiterated in many settings, is like, oh, this study shows that cloth masks don't work. And it's like, well, actually, we found that cloth masks do lead to a reduction in symptoms. We just weren't powered for symptomatic seropositivity. But also the main point of the study was in the bottom line pre-registered primary outcome, pooling everything, that we did find effects. So this, I felt, was like a pretty misleading way of summarizing the study. And he was also like, he went around saying everywhere, oh, the results are really small. Now, to be clear, Jay is someone, before he became the head of the NIH during COVID, he had a very, his initial take on COVID was like, oh, so I think all of the epidemiologists are mismeasuring seropositivity. And in fact, way more people have been infected than they think. And so fewer than 10,000 people will die in total, right? He was mistaken about that. He also was part of this Great Barrington Declaration about, oh, maybe we should just be protecting elderly people and not younger people. And there, I'd say, I think we don't know. That was at the time certainly a viable thing to say, and I think these
should have been, in my opinion,
right. Like this is
part of the debate that should is expected to take place at a time like that.
So this was a totally reasonable like proposition to put forward. I think at the time he probably like overemphasized the strength of the evidence in the same way that when he encountered a mass study, he sort of like conveniently framed it as supporting his previous position, when in fact,
the results indicated
really,
something different.
I don't think it really did. But when he was nominated for the head of the NIH, a bunch of news outlets interviewed me, and I felt like they actually did a good job of summarizing my view, which is like, you should clearly support this nomination because he is better than whoever the next best person will be if he's not supported. Like, he's way better than like RFK or something like that. He's tendentious and political, but at least he has some notion of what's going on in science.
He's a very smart colleague.
Yeah,
so,
yeah,
yes,
exactly.
I agree with that. But in the reaction that you just described, like, did you see? I imagine that the answer will be yes, but I just want you to just comment a little bit on the type of reaction that is essentially motivated by pre-existing biases, ideological biases, political biases.
On both sides.
On both sides.
I would say, of course, the negative reaction to the masking study was from the side of the political spectrum that doesn't like masking. And then there were also people on the left who really distorted it, I think, in terms of sort of extrapolating. So I have, for the entire duration of COVID and even now, remain ambivalent about, for example, masking in schools or among young children, because exactly the types of things that Jay was pointing out, which is, and Jay was not the only one pointing this out, of course, that mortality was way higher among elderly people. So if you're doing masking in schools, it's really to prevent secondary infections. But it didn't strike me as insane. It's a debatable thing you could try to do. My view was we really had very little evidence on the impact of masking in schools on educational outcomes.
That's interesting. But outside of schools, would you say that the results have been used to support masking mandates or strong encouragements in contexts different than rural Bangladesh? Have they been used this way?
Yeah. So let me first say,
should they be used this way?
Yeah, my view on how things should go. So my view on how things should go is do cost benefit analysis. Like, holy God, the one thing I've been saying the entire pandemic for every single thing over and over again is you have to make some attempt to quantitatively weigh the costs and benefits in any given context.
Important.
Right? So if you don't do that, you cannot know anything, right? So there were people on the right who didn't do this and people on the left who didn't do this, where it's like you have to, so there eventually what happened is over time, COVID started out, it had this really high mortality rate. Then a lot of people got vaccinated. The mortality and morbidity started falling. The later strains probably were lower mortality, even conditional on vaccination status. Once that happens, the value of wearing masks is smaller because you're preventing COVID infections, but you're preventing, or maybe you're preventing infections, you're preventing morbidity from COVID. So but if there's less morbidity to begin with, a given percentage reduction in morbidity is less valuable. It's not like wearing masks is of zero cost. It's kind of uncomfortable. I don't want to sit here in my office wearing a mask all day. It's like I'd have a pretty reasonable willingness to pay to not do that. Is that willingness to pay $1,000 a day? Probably not, unless you're
Probably
very
not.
rich. But that willingness to pay might be, $20 a day or $50 a day, something like that. So it could be pretty big. So you have to weigh those costs against the benefits. Now, my view is if we're talking like July of 2021 or something, when many, many people were still dying of COVID, at that point, I think everyone was basically erring on the side of like the general error was too little mask wearing, right? But then by the time we get to, July of 2022 or something like that, where vaccinations are more widespread, morbidity and mortality start like a fall dramatically, then it's like, okay, now we're at the point where you really need to debate this. So in terms of what was too excessive, the main things I think were too excessive actually were just keeping schools closed. I think that was the most harmful thing where there was some prolonged policy response that I think was excessive. In terms of the mask wearing, I think we still don't really have great estimates of the costs. We still don't really know if people wear masks in schools, did it inhibit learning? Was it just uncomfortable? So it's hard for me to say whether that went on for too long. There's a lot of settings where I'm just ambivalent. And the other ambivalence that we mentioned earlier is, what is the long-term effect? Right? Like I mentioned, at the time when we did this study, the rationale that I would give is like, look, vaccines are coming. If you're in a setting where lots of people are dying, like you should still be wearing masks now to prevent COVID. And ideally, what will happen is, even if you end up in a world where COVID is endemic, which we did, where most people eventually get COVID, hopefully they'll get it at a time when they're less likely to die of it, right? When they're either vaccinated or the strains are less severe. So that was sort of the rationale at the time, which I think might have been correct. Let me give one piece of sort of contrary evidence that I'm still not entirely sure what to make of, which is there's an interesting study by one of my colleagues, Paul Goldsmith-Pinkham, that looks at mortality among Democrats and Republicans before and after vaccines. And so what he finds is that there's a fairly large difference between Democrats and Republicans that emerges after vaccines became widely available, and there's very little difference before vaccines. Now, this is not isolating the impact of masking. There are lots of things that happened prior to vaccines being rolled out, right? And you might think that many of them would go in the direction of the Democrats being more protected, like things like, they were just more cautious in general. Now, one thing that you could try to do is say, can like a study like this rule out magnitudes that are comparable to what we see
with your results?
And when I tried to run the numbers, probably you can't rule them out, but let me say what it can potentially rule out is, so you could take our study and then you can embed it in different epidemiological models that will make different predictions about how, if there was more widespread masking, how those would impact the course of the epidemic. Now, it becomes very complicated if you're like, well, if people wear masks in California, but they don't wear masks in Nevada or whatever, and then there's a lot of intermingling between them. Depending on what assumptions you make, you can get all kinds of different things, but this can rule out some versions of those models that are like, oh, basically, if you have widespread mask wearing in California, it ought to, just dramatically reduce by like 50% or something the total number of infections. No, when I say rule out, there's still this big unknown, which is we still don't have great counts even in like democratic states of how widespread was mask wearing, but certainly anecdotally there's a sense. I'd be surprised if in the early days of the pandemic it actually weren't reasonably substantial in some of these states. So I think that's probably not the full explanation, and I think studies like this are informative about like the overall long-term impact of masking. But the main thing I would highlight is just the uncertainty that it's like the state of these epidemiological models is still sort of very primitive. We just don't know a lot about how to make like accurate predictions about the impact of interventions like masking on the long-term evolution of pandemics.
Yeah, that's super interesting. So since your study was published, were there any other studies that on the same, that also tried to estimate the impact of masks that came out? And
there weren't any like large randomized experiments of the same scale. There were other, what I refer to is natural experiments. So there was a study in the New England Journal of Medicine that did like a difference between schools that had mask mandates and didn't, and they found that actually they were effective. Now, one of the issues with a study like this is, so it's very hard to know.
There's so very little transmission within schools, right?
So they looked at, I believe they measured so it's not that there's very little transmission in schools, it's that there's very little morbidity. So, or like severe morbidity. So it's
Yeah.
like a child who gets COVID, like they're just as likely to get COVID. Well, actually, I shouldn't say just as likely. Well, the big difference between the elderly and the young people is conditional on being
Yeah.
infected. How severe is it?
Yes.
So it
Yes.
seems like they found that you were less
Mm.
likely to be infected. The other kind of caveat here, though, is that you really want an apples to apples comparison between the control and treatment schools. So what does that mean? You kind of need the entire history of the infections to be analogous between the two, because one of them
Hmm.
had more infections beforehand, they have more natural immunity. It's all
Exactly.
confusing. So they claimed in the study, they had some graphs which kind of suggested to me a surprising degree of actual, like, that actually they were matching pretty well between the
Yeah.
treatment and control things. Then there was a follow-up study that was like, oh, if you chose the control schools differently, then they don't find an effect. But that study didn't really show the graph that they chose the control schools, so they were parallel. So my overall takeaway from this was like, maybe this was slight evidence in favor of masking, but just like the vaccine or the Republican Democrat, I think study I mentioned was like slight evidence against it. But I'd say basically since our study, I don't think the overall status quo about masking changed very much. I think maybe we had like this. I became slightly more pessimistic about the long-term impact, although mainly still just agnostic, and then slightly more optimistic about the short-term impact, although I think our study provides clearer evidence on that.
Understand. So two final questions. One is, and I think I already know part of the answer. Like, if you were to design a follow-up to
Yes.
this study,
Okay.
in addition to
Yes.
testing everyone, like you
Yes.
already mentioned,
Yeah.
what would you change?
Yeah, let me say some new things. So there was testing everyone. There was another thing, by the way, that we considered doing, but we couldn't. By the time we brought it together, we felt like it was a little bit too late. Was masking in schools, trying to monitor the educational
Okay.
outcomes and things like that. But basically, by the time we did it, we were like, probably there's not really a good public policy rationale for this, so we shouldn't do this. We shouldn't do this intervention. Let me think. I had a few. So just like the technical things we discussed about if we had more time, we would, the things that we think might have been responsible for balance failures are pretty easy to fix. So we would fix those things.
Now, is this a study that, like this hypothetical follow-up study, is this study that could be done, like, say, during a flu season?
Yeah. So
Do
we
we need a
actually,
pandemic to do a study
very
like
good,
this?
very good question. We considered that. Like my view is, I'm not sure the cost benefits are there to mask everyone during
Got
flu
it.
season in a school.
Great
However,
point.
what I would say is the following. I definitely think you could do a study like this. I've considered it. It's just, I haven't found just the right setting yet, but it might still happen, which is masking individuals. So basically be like, look, we're going to take, if you have any symptoms, you know, maybe you should stay home, but if you come to school and you have symptoms, you should wear a mask. And then we can see, how does this impact your learning? How does this impact your performance? Right. And to be clear, I'm still a little bit agnostic. The thing I said about everyone masking, it really depends. You want to do the cost benefit calculation. There's some settings where it might pass and some settings where it might fail. If you find a setting where it passes, I think it's a very reasonable study.
Oh, I'm with you. Like the other day I was flying
Yeah.
and the person just behind me was coughing and sneezing the entire
Yeah.
flight. And I'm like, maybe you should wear a mask.
Exactly. Maybe you should wear a mask. There, I think
Maybe I should wear a mask.
exactly.
Right? Yeah.
But exactly.
Yeah.
I think there's a very strong case for it. Yeah.
Okay. And do you think that, based on your study, the reactions to it, your interaction with journalists, colleagues, and the public, what have we learned? Did we learn something that could, be useful in case of future pandemics?
No, I mean, I think the scientific community certainly learned some stuff. And it's like, I mean, to be clear, it's not like I revised my view of Twitter or the public much from this. It's like I did the study and the response was roughly what I expected, which is, a bunch of crazy people yell at you. And then, but I was not surprised by that response being a veteran of Twitter in the past. So, but I think, in terms of the things that we learned. So if there were a future respiratory pandemic that were very high mortality. So first of all, we have this set of strategies that we can probably use in places where things are not too politicized to increase mask wearing. I think we have stronger evidence now that like community mask wearing is possible, but returning to some of the points I discussed earlier, like if you're going to use mask wearing as part of a public health strategy to deal with an epidemic or a pandemic, like it's very important to get people to wear masks. So it's like, If what you're going to do is be like, oh, we're going to send masks to people's homes and hope they wear it, and it's something with comparable mortality to COVID, it's probably not going to work. It's probably not enough. You need a little bit of a stronger push. And I mean, the main takeaway from our study, I think, in terms of getting people to wear masks, is very intuitive, which is it's like, oh, if a bunch of people are in a church or something, and a person is at the door handing out masks and saying, hey, please put this on, most people are going to be like, sure. They're not going to be like, no, let's fight or something like that, right? Like maybe in some places now they would be, but once that fades from memory, they won't even be in those places either.
Great. This was great. Professor Jason Abaluck, thank you so much.
All right. Thank you.